don't take well to challenges. Or I take very well to. I'd like to call this order in session, this hearing in session. Sorry, thank you. I'm Councilor Anissa Asaibi George, Chair of the Committee on Homelessness, Mental Health and Recovery. Today we are considering docket number 0483, a hearing regarding our partners in the fight against substance abuse. I want to remind everyone that this hearing is being recorded and broadcast live on Comcast 8 and RCN 83. I ask that you please turn off your cell phones and anything else that makes noise. I'd like to next recognize my colleagues, Councilor Linehan and Councilor McCarthy. Sorry, I apologize. We will be taking public testimony at the end of this, at the panel session, so please sign in at the front and mark that you would like to testify. Please state and when you do testify, please state your name, affiliation, and residence, and try to limit your remarks so we could hear everyone else's comments. All right, welcome everyone, and thank you so much for being here today. We'll have a series of 3 panels. Our first is with us. I would like to just open with a few remarks and comment on this incredible challenge that we face as a city and the incredible work that all of you are doing in this space. It's an affliction. Substance use disorder is an affliction that brings profound human cost to individuals and families and communities at large, without regard for class or color boundaries. It brings enormous financial costs to the city and the Commonwealth. And for those reasons and many more, that's why we are here today. Some of our focus, and I know some of your focus, is in the work of prevention, intervention, treatment, and recovery, and that we need to make sure that all of our residents are receiving a high level of care. We will hear from all of you, but I'd like to give this opportunity now to my counselors, Linehan and McCarthy, for opening comments. Thank you. Councilor Linehan.
Thank you, Madam Chair, and thank you for hosting this hearing. The Boston City Council has been extremely active for at least all of my tenure, if not before, 9 years on the council, in trying to improve opportunities for those in recovery, to reduce those in addiction, and to work with you, the providers, who do an extraordinary job. I want to thank you not just for being here, but for all the work that you do and all that you represent. I know that it's an extraordinary network of people throughout Boston and Greater Boston who do God's work, actually, every single day in trying to bring people closer to recovery, through recovery, and then therefore making families better, making streets better, making enclaves and communities better, and making our city better. So I'm glad that you take the time to be here. My questions will be pointed generally at, after you make your presentation, on resources and how we acquire the necessary resources to affect this not only scourge, but an epidemic, but this extreme rise of what's going on in and around opiate. And I just say my focus is addiction and recovery, not one specific kind of addiction, but all addiction and all recovery, and those things associated with it, such as mental illness. So, thank you, and thank you, Madam Chair, for hosting it.
Thank you. Councilor McCarthy.
Thank you very much, Madam Chair. I'd like to thank my good friends and colleagues for allowing me to be a part of this great fight that we continue, and certainly that you continue daily. We're fighting not only the opiate addiction, but we're also fighting the stigma of what it brings upon us. And what we have to continue to do with this fight is to make sure that stigma is erased, and that people understand that it is a disease. And we're here, with experts, and experts, as Councilor Linehan said, who do God's work, who don't sleep very well at night, worrying about their customers, if you will. And we're here to ask you questions to see how we can utilize our authority, or our bully pulpit, if you will, to move us all forward, how to address the many complicated issues, whether it's with the healthcare, with mass health, what we can do within our city. And, we've done as Council Linehan again stated, we've done a good job so far. We continue to work very hard. And, Jen Tracy's here with us, and she's the first director of the Mayor's Office of Recovery Services. And she is neck deep in this and doing a wonderful job. So it's wonderful to see a lot of people that are very familiar to the chamber and specifically attacking this stigma and this scourge that is going throughout the country. So I'm looking forward to asking questions and learning from you, and I appreciate you being here. Thank you.
Thank you, Councilor McCarthy. And I think that your closing comment there about learning is what we need to focus on, I think, for today, for us to learn more about what we're facing as a city and learn more about the work that you're doing and what you're facing as organizations and city agencies and nonprofit partners and for-profit partners, because it's incredible work that's happening in that field. And really help me better understand how as a city and as a city council we can do more to support your work. So for our first panel, if you would just introduce yourself and tell us about your work, but we'll start with Jen Tracy and Brendan Little, who come from the Mayor's Office of Recovery Services. Thank you for being here today.
Thank you. And thank you, Councilors Asabi George, Linehan, and McCarthy, for the opportunity to be here today with you and so many of our partners. As you stated, my name is Jen Tracy, and I'm the Director of the Mayor's Office of Recovery Services, and I've asked Brendan Little to sit here also from the Office of Recovery Services with me. In Boston, we are fortunate to have so many committed providers of treatment and recovery services who work in our city. I'm happy to see so many of them here today in this room. My goal for today is to say a few words and then to listen to what others have to say about how we could be more effective in our work together. As you know, the office is charged with trying to coordinate our resources and find a way to strengthen our continuum of care without investing significant additional dollars into the system. The office builds upon Boston's existing recovery service landscape while also increasing overall awareness and expanding the scope and breadth of services. All families should know where to turn when a loved one needs help. We need to get the message out to young people that there are supports in their communities to help them deal with their problems. They do not have to turn to drugs and alcohol. I see my role as the spokesperson for the needs of Boston's treatment community. We will tackle these problems through enhanced communication and referral, identification of new funding opportunities, and by bringing the city's voice to the table at the state and federal level. And that is why today's forum is so valuable, because it gives us an opportunity to hear from everyone and to think about next steps. But before I turn it over, I'd like to add some context to the work that we all do in Boston. Like so many other parts of the Commonwealth, we have seen a steep increase in the number of unintentional overdoses in the city. Unlike other cities, Boston has been managing a growing heroin problem for a number of years and has helped to build the list of successful interventions. We were the first city in the state to get Narcan into the hands of active users and their family members, which has prevented thousands of unnecessary deaths in the city, and we continue to do so. We were among the first to establish a needle exchange program preventing the spread of HIV and hepatitis C. Through the Recovery Bureau's PATHS program, the City of Boston coordinates the only one-stop referral to care program of its kind in Massachusetts, facilitating access to treatment and other resources, giving individuals and families access to recovery services on a walk-in, real-time basis. And now, as you stated, Boston is the first in the nation to have a municipal Office of Recovery Services. And now, moving forward, Office of Recovery Services will increase access and awareness to recovery services by partnering with the mayor's constituent call line, 311, so that anyone in Boston can call one centralized point for questions or referrals for treatment and recovery support services. Boston Police, Boston Fire, and EMS are now equipped with recovery resource cards for the first time in Boston's history. There are over 5,000 in circulation. The office is partnering with the Mayor's Office of Public Safety and the Suffolk County Sheriff's Department to facilitate more comprehensive reentry services. For the first time, We will be developing a citywide substance use prevention strategy by leveraging relationships with local schools, youth, and community partners. I hope that today's hearing will lead to even more ways to ensure that Boston remains at the cutting edge of substance use prevention and treatment services. And I truly believe that we are building partnerships across the city that will have a greater impact on the health of individuals and communities in a way that we have not yet seen to date. I look forward to your questions and hearing more from our community partners. Thank you.
Thank you very much. Helen Conley, Executive Director of the Alston Brighton Substance Abuse Task Force.
Good afternoon. Just to reintroduce myself, I am Helen Conley. I'm from the Alston Brighton Substance Abuse Task Force, and I'm delighted to be here today. Thank you, Councilor Asabi George, Linehan, and McCarthy. I am here because I would like to speak a few moments about the value of prevention on the continuum of care. So as we look at the substance abuse problem in the city of Boston, there's three components: of prevention, intervention, and recovery. Prevention has been going on in the city for at least 10 years and more in the form of neighborhood coalitions. There are several of them who have been working, feverishly at trying to identify the risk and protective factors that lead our youth to move on to using substances of abuse, and ranging from alcohol and unfortunately all the way up to heroin. We have been really, I think, on the forefront of prevention. Alston Brighton has been very fortunate because we received a 10-year grant from the SAMHSA, federal SAMHSA drug-free community grant, as did a few other of the coalitions. And that grant sustained us for 10 years. We were able to do a lot with that grant. We were able to build capacity, build a very vibrant coalition with various stakeholders from the community, including law enforcement, parents, youth, schools, colleges. And we were able to really, form working groups and really, look into the prevention field as a evidence-based, research-based program that it is. All of our strategies have been conducted after doing an assessment to collect this data and to really target the strategy to the appropriate age group and to look for the desired outcome and then to measure it. So it sounds like a lot, and it is a lot, but it also, at the end of the 10 years, ourselves, Alston Brighton, like the other coalitions, were faced with a, sustainability issue. How are we going to continue all these great prevention strategies because this particular federal grant is not renewable after 10 years? We're fortunate in that we've received some funding from St. Elizabeth's Medical Center. We are working in partnership with the Boston Public Health Commission. We're at the table on there as a member of the leadership team for the Substance Abuse Prevention Collaborative. And we look forward, as Jen mentioned, to working closely with the commission in the office on the citywide prevention plan. So although we have a strong neighborhood focus, we have been working alongside and with the city partners in areas that have been attainable and where we've had the resources. One such strategy is the prescription drug strategy that we launched with the Boston Public Health Commission, where we had worked hard to get those kiosks in the local police station, and then to follow that up and make that a sustainable activity, a prevention strategy. And that would be to, involve the community, to keep up the correspondence, the advertising, if you will, the notification of the community and key stakeholders that disposing of prescription medications from your medicine cabinet is one of the easiest and yet most effective prevention strategies that one can do to keep those meds out of the, the hands of teens and other youth. We know that 70% of teens who misuse prescription drugs get them from home. They get them from family and friends. That's heavily documented phenomenon, and that is an area where we have worked very hard to try to reduce that, obvious risk factor, access to drugs. We've done a lot with alcohol. Alcohol is a major source of substance use among our youth. A lot of the studies, will tell you that alcohol, is probably the most widely abused substance among youth, and that, and therefore we are and have been working on several strategies to reduce underage drinking in the community. Yeah, we've done things like retailer training, beverage training. We've worked with the Boston police local police, to form a youth coalition where they actually go out and put stickers on alcohol boxes in various liquor stores that alert people that it's against the law to buy for under age 21. Those are just a few examples of some of the strategies that we've employed. We'd like to continue doing many of those strategies, and we also look forward to working, as I mentioned, with the Commission and with the Office for Recovery where we can. Our work has also involved policy change, and that's a very important aspect of prevention. We have, with our youth coalition members, also with help from the City of Boston, certainly the state level, and our own stakeholders in our community, the Austin Brighton youth group was able to work towards a ban on alcohol advertising on the MBTA. That was a major feat for our group, and that occurred back in 2012. And that's probably, the pinnacle of great prevention. There was a lot of work done beforehand, gathering data, taking pictures of these ads, and actually, looking at the research to document that these ads were harmful to youth and actually contributed to underage drinking. As we look forward, and I also want to mention, I know one other thing, and it's very important, is that we also have been hosting an annual Walk for Recovery. That has been going on we'll have our 12th annual walk this September. We started off doing that in partnership with MORE, Massachusetts Organization for Addiction Recovery, St. Elizabeth's, the Granada House in Brighton, Alston, ATC&E. We have a lot of treatment and recovery partners, and we'll be doing that again this year. Areas for improvement that, I would like to recommend as a person who's done prevention and has listened to the community and the stakeholders, that, we would like to see that prevention continues to be a recognized major component on the substance abuse continuum of care. I mean, all that can be done, should be done to prevent this scourge of this disease to start. We also would like to propose that the systems throughout the city, actually, if we could get better data, youth data, and analysis of that data so that we can use that information to better inform our strategies. Also, we recommend partnerships, developing more partnerships or stronger partnerships within the City of Boston and with other key stakeholders to allow us to continue our work. And lastly, certainly funding sources. Always looking for funding sources to augment the sustainability of the work at the neighborhood level, but also to help us to achieve a greater involvement in a citywide level. Thank you.
Thank you very much. Next, we have Jen. I'd like to introduce yourself.
Hi, Chairwoman Asabi George, Councilor Linehan, and Councilor McCarthy. Thank you so much for this opportunity to speak to you today. My name is Jen Irby-Leggett. I'm a clinical social worker, and I come before you to talk about my experiences as the owner and director of an outpatient behavioral health practice in Boston. My voice represents the private, sometimes isolated treatment providers that comprise a substantial part of the network of prevention and aftercare or relapse prevention treatment available to Boston residents when dealing with substance abuse crises. My practice employs 13 highly skilled therapists who provide outpatient therapy services to residents presenting with a wide range of mental health and substance abuse issues across a full spectrum of problem severity. We see people just identifying mild substance abuse as a bad habit that they'd like to address, through to people requiring immediate detox, rehab, or psychiatric hospitalization. We then also see people on the other side of such an intense inpatient treatment experience, helping them reintegrate into their everyday lives with new skills and new strength to replace past unhealthy behaviors with new ones. Our private outpatient setting is freestanding, cost-effective, and community-based. We spend a great deal of time listening to the struggles of the general population and helping them with our professional services as well as advocacy. I've been in my current role as the owner and director of my practice for 3 years now. My practice has experienced tremendous growth since we started, based on the skyrocketing needs presented by Boston residents, as well as the distinct lack of a sufficient number of therapy appointments available for people using commercial or federal health insurance products. To be clear, our city is inundated with therapists. We have an embarrassment of riches with all of our graduate schools producing great providers, but the factors at play here with healthcare reform make it such that a growing percentage of providers do not take the health insurance that is available to our residents, especially the most fragile ones. The issue I would like your help with most is ensuring access to therapy for prevention and treatment of substance abuse problems. That access is simply not widely enough available in our city, and the problem is getting worse by the second. Data and common sense show that prevention of large problems like these before they escalate is the most humane, effective, and cost-effective path for a city to take, and yet Boston is not set up well from where I sit to provide this preventive care. Attorney General Maura Healey's June 2015 report documented barriers to care in substance abuse and mental health treatment and was an excellent descriptor of this public health crisis. It speaks frankly about the factors at play here, specifically historically low reimbursement rates that are paid to behavioral health and substance abuse providers for their services. She outlined clearly how these factors have changed the landscape of available therapy in Boston over the past few years, with hospitals and large healthcare systems significantly reducing the amount of outpatient therapy they provide for mental health and substance abuse, due to the fact that behavioral health and substance abuse is a negative business for general acute care hospitals. That is, they lose money on it. From where I sit, I have seen that effect grow as we are now seeing large primary care medical settings and systems follow suit and reduce the amount of money-losing outpatient therapy they are providing and pushing it out to community providers like me. Now, this may be a necessary market correction, but the problem is there are simply not enough providers right now who take low-paying insurance right at this moment to treat the escalating number of cases we are being presented with. And this problem is at crisis levels. How do I see this? I see this when parents call me to get behavioral health or substance abuse therapy for their adolescent, and they report that they have called 25 places and had not one call back. I see this when a new struggling mom on Mass Health walks into my office, which happened 2 weeks ago, asking for care and reporting that the last time she had a child and struggled with postpartum depression and substance abuse, she received a total of 4 visits over a year from a community health center. I see this when my staff people come to me seeing that their paychecks have gone down, a direct result of us being flooded with one of the worst paying insurances available, and when a local medical system sent us all of their behavioral health and substance abuse cases, and then when I realized that this very insurance is the one that the Boston Teachers Union, firefighters, union, police, and much of City Hall employees are now enrolled in. If my practice can't afford to keep taking that insurance, even in our lower cost setting, our 600-plus clients are going to be in real trouble finding a therapist to see them. Clinics and nonprofits are also closing all over the city due to these rate cuts, and this affects Boston a great deal. These were the places we as providers could count on to send a patient with a poorly paying insurance, and now those therapy seats are just not available. These are the very seats that would help someone avoid a greater substance abuse problem in the future and recover from one after being hospitalized. The seats available are too few and getting more and more rare. My main point is this. Most substance abuse problems are paired with behavioral health issues or mood disorders. When a person struggling with depression and substance abuse is brave enough to raise their hand and ask for help, they should get it, not hear that everyone they call is unavailable. This response is inhumane and irresponsible. These problems are complex and require readily available treatment to stop them early in their tracks or to prevent them from occurring after potentially life-threatening crisis. Our city's response must be equally complex. Please don't stop ensuring that beds and detoxes and rehabs or spots in partial and day programs. Those are essential. But without the guarantee of adequate preventive, early stage, and relapse prevention aftercare, we're not providing a responsible array of care to compassionately, effectively, and cost-efficiently address these growing societal issues. Thank you.
Jen, thank you so much.
Good afternoon.
Fred, thank you. Thank you.
That's okay. My name is Fred Newton. I'm the president and CEO of Hope House, and I am grateful and honored to be here. Councilman Linehan, Esaba, and McCarthy. I'm also honored in the past year and a half or more to have sat on the governor's opiate work group, where we really got a chance to go across the state and to see the devastation that the opiate crisis has wreaked on the entire state, to be honest with you. Everybody is struggling with it. So as the director of Hope House, we are We have a 95-bed residential program, long-term residential recovery home. We have a small housing program, subsidized housing program, which I think is a great example of society in general. We have 95 treatment beds and we have 22 housing units. And I think that's probably the same odds anybody coming out of treatment is facing. So I think that a big problem is in sanitary, safe housing for people that are in recovery. We also have a small outreach program that we try to talk to some of the local school systems, particularly the high schools around this time of year. And we have a full outpatient clinic. Part of the outpatient clinic is now, we actually just started it officially this week. We have now have a SOAP program, which is a structured outpatient addiction program. So it's an intensive outpatient program for up to 21 days for a person to come every day and go to 4 groups a day. So we're hoping that will help. We also, at Hope House, we also have the Federal Bureau of Prison contract. So we have quite a busy spot sometimes with traffic coming in and out. And so that's the problem with the neighborhood. I just came from another interview with a radio station, and we took a walk around the neighborhood, and we walked right into 3 people who still had needles in their appendages. It's sad for us as a person in treatment, but I think we have to be able to reach out to these folks that are on the street and try to get them into treatment. We know that law enforcement doesn't help. I mean, locking them up is not the answer. How we reach them all, I vacillate between answers. I know when my car doesn't work. I don't know how to fix it, but I know it doesn't work. And so I think that we really need to look at the so-called methadone mile and see how we can better manage that. I've been in this business for well over 30 years. I'm in recovery myself for 34 years. I've never seen anything like it. But I do want to echo Helen's comments too, that sometimes we forget alcohol. Alcohol is still killing more people than any other drug out there. So we cannot forget any of it. I'm not sure what else to say. I wasn't really prepared to come, but I'm certainly happy to answer any questions that we have. I'll just wrap up by saying thank you. And actually, it's great to be in a room full of my peers and friends. And thank you very much.
Thank you so much, and congratulations on your recovery. How much, and Helen mentioned and Fred mentioned the alcohol question, and so often in sort of the public space, we talk about addiction to drugs, a various variety of types. And heroin certainly is in the forefront of our conversations these days. But how much do the grants that all of you depend on, or many of you depend on, drive your focus? And I guess, Helen, this may apply a little bit more to you, but I'm curious as to that, because sometimes we go where the money is as opposed to where the need is.
Well, for instance, for our community, when we were recipients of the SAMHSA grant, the Drug-Free Community Grant, it was our task to assess the community and then to determine what our target substances were. And for our community, our neighborhood, I should say, they were alcohol, tobacco, alcohol, prescription drugs, and marijuana. And so those were the 3 substances that we were funded via the Drug-Free Community Grant to address in our community. Other neighborhoods did their own assessment and came up with a different set of data. So, I'm referencing that grant because that grant was set up in that way that it made sense that we would, look at what are the specific issues in a certain community and then go after that instead of doing, generalized, prevention. The SAPSI grant that BSAS has issued, and the Boston Public Health Commission is the grantee. But the task force and a few other coalition members are at the leadership table. And that grant right now was written out so that we could address underage drinking and other drugs. But we are conducting an assessment to make sure that there are not other substances outside of the realm of the two I just mentioned that need to get addressed.
And I'm going to turn to my colleagues for their questions, but one more comment. Your commentary about the prevention work, because we do, I think, more recently talk a lot about the recovery work, but that prevention is more important in so many ways if we can get to it first. And I'm going to turn it over to Councilor Linehan, but first recognize we've been joined by Councilor Matt O'Malley. Thank you. Councilor Linehan.
Thank you, Madam Chair. Again, thank all of you for what you do. It's extraordinary work and difficult work every single day, but so needed. I marked a few things down for each individual, so if I could, I'll work back. With Fred, you had talked about the issue around aftercare, after recovery. Your recovery services are applied monthly, 30 days, 90 days, what?
So the long-term treatment program is up to 6 months
Okay,
that they stay with us, but then they need to go on to some sort of, again,
so then you're saying that as they leave, that less than half, or maybe 1/4, have an opportunity, is that correct?
it's difficult, yeah.
And where do they go?
So, I mean, they can go, today's clients are a lot younger than they used to be in my day.
Yep.
And so there are still family options
Yep.
quite often. Sometimes it's sober housing that they go to, which is difficult to find.
Yep.
Because the good ones are always full.
Booked, yep.
Sometimes they'll get 2 or 3 of them together and split a rent someplace. Again, the clients are really not, there's not a lot of high-paying salaries for them. They have trouble finding jobs. Most of them are getting entry-level jobs because of quarries,
Yep.
which is another serious problem. So, and rents are high. And
So what percentage of them end up back at Hope House?
I don't really know, to be honest with you.
Yep.
I always
Just a rhetorical
reference that by
guess.
saying it's a 50-50 shot.
50/50 that's a good estimate too, right? 50/50.
Yeah, probably closer to 40-60, but
Yep.
I like to think positively.
Yeah, no, well, 40 people that have recovered is, out of 100 is still quite an accomplishment when you think about how difficult the task is.
It is, and I think that sometimes, like each individual house, and there's a number of them throughout the state, right? And even in the city here. So if you look at an individual house's statistics, you might say, well, that's not so good. But as a system, I think it really works pretty good because quite often these are people that have really strong relapse histories. And so they might go through 4 or 5 houses. And then in that 5th house, something clicks and it works. But so the system was there as part of their journey, if you will. But the one house that it worked at is the one that gets the...
Do you have any idea how many people are in long-term recovery at this point, say like in the state of Massachusetts?
Oh, gee, because I have no idea. No idea. I know I have a 6-week waiting list to get into Hope House.
Okay. So my question, resources. If you had more resources, you could do what?
We could treat more people. Obviously, we would have more beds and more treatment.
Would you apply some of that outside your, like if you had a certain amount of money, would you apply it not only just to recovery services, but those services that need to happen afterwards?
If I had the opportunity to do that, absolutely. 80% tile, somewhere in that percentage of the guys that come into Hope House are homeless. A higher percentage are unemployed. Not very well educated, quite often haven't even got a GED. So sometimes it's frustrating from my perspective because I got a young person that I should be putting in a GED program or finishing up a class that they need to get some sort of degree, and I'm pushing them out to get, an $8 an hour job because they have to pay their treatment fee. So it's sort of,
All right, thank you for that. Jen with one N, thank you for what you do, and your information today that you've availed us is pretty powerful. So if you could recommend, if you have 14 clinicians, and that there are so many people looking for your service, you can barely keep your own clinicians due to the pay. Am I accurate? And then 25, a woman makes 25 calls, and she finally gets to you and you return the call. What is the scope that's needed? And did you have any, like even in an intention, right? Not so much a program, but an intention, what would be applied in resources to address and improve that situation? Because I think you were extremely accurate in stating that relapse counseling, prevention counseling, even intervention counseling, all that sort of stuff just makes the world a difference before we have to go see Fred,
So I think what I know, before we saw these factors shifting care a whole lot more within the city, we were doing pretty well. People are making modest salaries at my office and doing great care. And the big shift for us that really alarmed us was when we saw, when we've continued to see hospitals stop providing any outpatient therapy for behavioral health or substance abuse, or very little, as well as a large primary care setting in the city that really, I think, responding to healthcare reform has been trying to have a different model. What the result is, it pushes a tremendous amount of that care out into the community, and it's the lower paying care. And so when we were flooded with that, my employees are employees, but they get paid only for what they do. They had this lower paying insurance and their paychecks went down and they were doing more work. And so they came to me and said, we're already not getting paid very much. This is nuts. And so I started to try to get people's attention because, that's a problem. And I think when I realized that, particularly a number of our clients were city employees, that's when I started to reach out to the council in terms of, what kind of help we might be able to get with that issue. I mean, I think the rates that providers are paid, both at the hospital level as well as the outpatient level, is a substantial part of this. And Maura Healey documented that it's Attorney General Healey documented that it's the lowest rates we've had in 15 years. I mean, it's substantially lower than it's ever been, and so that's really hard to continue to operate those services. And we'll be okay. My practice will be okay. What I'm more concerned about is the larger
right.
array of services.
And so where would the money come from that would either serve more people or to pay people more appropriately?
If I had a magic wand, I would like to compel insurance companies to pay a fairer rate to the providers of these treatment services.
Okay. Thank you. Helen, we don't hear as much about prevention services as we used to 20 years ago, 25 years ago, with Boston Against Drugs and all these folks were sending money, and corporations were participating in this throughout every single neighborhood of the city. You've been fortunate to sustain your activity, and congratulations in doing that. Is your grant over, and that the large amount, how much was the grant from the Fed?
It was $125,000 a year.
A year?
Yes.
And when does that end?
That ended for us in 2014.
And how are you making up that money?
Right now, we are fortunate in that we have some time-limited but funding from St. Elizabeth's Medical Center as we seek to apply for other grants from foundations and outside sources. We also, as I mentioned earlier, receive a grant from, we're partners with Boston Public Health Commission on the Substance Abuse Prevention Collaborative Grant. So we do receive some funding there, and that supports, some staff salary.
How many other programs in the city are like yours?
I would say there are about 7, maybe, I can't say exactly, but 5 or 6 in the city itself. Each of us is different in terms of our infrastructure and our funding sources. Some are associated with major hospitals, some are freestanding, some are health centers, some with, so that's part of the issue there, that we're not all funded the same, nor is our organizational structure the same. And, quite frankly, our concern of 2 years ago, and St. Elizabeth's helped us out with that for the short term anyway, is that, how are we going to continue? And it's going to be tough because it's difficult to find funding for organizational infrastructure.
We don't only need to make sure that you're funded, but we need to make sure that the program is replicated throughout the city and every single neighborhood of the
Exactly.
city, which doesn't happen anymore. And we need to do that. So your information and your practices of collecting data to help direct, through assessments, direct energy and services are real important. Thank you. And Jen, with two ends, this is your first year under enormous stress and strain of what's been going on in the recovery community. The issues continue to grow, and presently your budget's around $300,000. Is that right? Yeah. And the budget, is it approximately the same for this new budget? I haven't looked in the budget item.
We actually got funded for the 311 initiative, so a small, an increase to support that.
Oh, okay. So
Which
that
is really
that
exciting.
that's directed at your line item, and it's a certain component that will go to 311
Right.
that allow people to contact 311 and access services from.
It'll go in the commission, the Recovery Services Bureau line item for the Boston Public Health Commission to hire 3 staff
Okay.
to be the wall behind the 311. So to
Yep.
back up 311.
Oh, I see. So there'll actually be personnel right in your
They'll be
organization.
down with us. They'll be down with us on Albany Street, but there will be a direct connect from 311 to the staff. And also, many of the community providers in the room will be helping out in that initiative as far as getting people the resources in communities where they're at. So working with East Boston and Charlestown and all of the community providers that are out there, certainly we'll need to be working closely with them.
Okay. And I know that originally the concept was that there'd be some sort of clearinghouse for an application where if I needed to get someone into recovery or counseling or asking for a prevention program or whatever it was, and that we could efficiently find that sort of information for my specific need in my particular neighborhood. Has anything going on in that regard?
We've been focusing mostly on the access to services, and I know that was in the Blue Cross Blue Shield report.
Yep.
Don't believe it was a year 1 initiative.
Again, I ask every department head in the city, usually during a budget, if you had the amount of money that you to address major issues in this particular in your mission, do you get any idea how much money that would be?
I feel really fortunate to have the support of the mayor with this, and the fact that we actually were able to get approval for the initiative for 311
Yep.
is really exciting in these difficult times around the budget. So I think that the office has really focused on pulling people together. There's a tremendous amount of services and providers in Boston,
Right.
and increasing the communication lines, and even going, really to what Jen said, she's a private provider. That's really a goal of the office, is really to convene folks that haven't heard from the group that's sitting here about what services are available and how to get that message out to families and to individuals that are struggling. That's really been the focus
Right.
up till now.
So I just, with all of this panel and just this one panel out of 3, you say, wow, we need much more to do this right. We want you to be as capable as you possibly can and have the resources. So I know that this is flushing out the way to fix this, what we need to fix it. I said in the beginning, I'm going to focus on what resources we need. But so that's just with one panel. We've seen so much. And I want to thank you again for what you're doing. And I want to help you specifically because you represent all of us in this fight. And we want to make sure that we're there to support you.
Thank you. I need your help. Thank you.
Thank you, Councilor Linehan. Councilor McCarthy.
Thank you very much, Madam Chair. Helen, you mentioned St. E's a couple of times. Is that Dr. Hamrock's program?
Well, Dr. Hamrock is, yes, the medical director for.
He's my doctor.
CCAP.
He's the best. He doesn't get any better than Dr. Ham. I'm sure is he Pat and Brian's your doctor too? Yeah. You guys are in pretty good shape. So, yeah, he's a great guy. I had to throw that out there. He's my doctor, and I wouldn't go anywhere else. I'm going to direct a lot of my questions to Jen. Jen stated that her office is in Boston. Her office is really in Rosendale, right in the square. And she and her clinicians are an integral part of our neighborhood. So it's wonderful to have you here. We met last in the wintertime because it was snowing. I remember that. And here we are. So we're moving along at a pretty good pace. I'm glad you're here. You and I have talked about the obstacles to access of long-term therapy. Can you dive into that a little bit?
Well, I think outpatient therapy, again, can be an incredible prevention of the need for any of these programs, especially when someone recognizes that there's an initial problem. And the biggest obstacle, the way I see it, is when people have insurances that are not well represented in the treatment community. The insurances still pay at vastly different rates, and the mass health products still pay substantially lower than some of those. And so, and individual contractors are prevented, legally prevented from collective bargaining. So we have a real difficulty advocating for ourselves and getting rates to be raised. And that really becomes the bottom line of the treatment of the provider community in terms of being able to stay in business, being able to open group practices like mine, or a huge number of providers have gone to self-pay, sort of boutique practices. And I used to be highly critical of them. And as it gets harder and harder to pay my mortgage, part of me understands why they do that. I'm not going to do that because I think we need to serve the residents. But I really think that in my setting, in order to get a seat for therapy, you have to have a great insurance and get lucky. But get the number of calls, Alyssa McSherry, our practice manager, the number of calls that she gets with people saying they've called 25, 30, the number is going up. And particularly for an adolescent with substance abuse issues or self-harm and suicidality, or any issue really, it's just astounding to me how many phone calls they make that they don't even get a call back, let alone then find someone who can take their insurance and give them a seat for therapy.
And we had talked about the preventative maintenance. When you're helping somebody get on the road to recovery, the health insurance people have to realize that, if preventative maintenance really is, if you don't change the oil in your car, at some point in time, you're going to have a major disaster. And that's what, you deal with so well. And briefly, we were going to talk, we had our conversation about hospitals and how they're trying to get out of the mental health business altogether. And you've made a statement today about Harvard Vanguard and West Roxbury getting out of behavioral health. I know exactly where that is because it's right next to the PEDS office. That's where I took my boys when they were little, so I know exactly where it is. So they're getting out. So now, where do those customers go? Where do those people who need it the most, who are paying with Harvard Vanguard? Clearly, they're getting out because they're not making enough money out of it, or?
I don't know all the reasons why they're closing that division at that particular site, but I do think that the healthcare reform and bringing behavioral health services together with medical services is a great idea. The way that's being managed is, I think, creating a glut of people that just can't find a seat for therapy. Again, as we said, and all the major hospitals really streamlined their behavioral health departments such that they're not doing a ton of outpatient therapy. That also happens to be really cost-losing medical services. And the community, I think, would be an ideal place for people to get some of that care, and yet there's just not enough providers that take those insurances because of the low rates. So I think in a way it's not a bad plan, but in the way it's being implemented, there's no way people are getting responsible care. And I think the people I worry about the most are, the highest stressed, lowest income. This woman who came to me pregnant with her second child and worried about, a relapse in her substance abuse issues, getting 4 appointments with Mass Health at a community health center. It's just horrifying. And so I think the people that are much more stressed, not, having the courage to raise their hand and then not getting a good response are the people we really need to worry about.
Thank you. My last question is based on, I think it's probably towards Jen and Brendan. Do we have the ability as a city to put pressure on our health insurance companies to make sure that at least the city of Boston, I know the fire is coming up, but fire, police, we've had some tragedies in the police very recently, as we may know. How do we, how can we put pressure on our insurance companies and the people who provide the city of Boston employees with better protection?
Well, I think that the city, through the Office of Recovery Service and other partners, can pull people to the table, and we can have these conversations. Certainly, I think that's something that could be done.
Yeah, because the conversation that Jen's having with people, who need the help the most, who aren't getting it, we have 19,000 employees here. So we should be certainly putting that to our bargaining units to make sure that our people are provided as well. And start here, keep, there's the old saying about keeping your own house clean. We probably should. So, thanks.
Thank you, Councilor McCarthy. And we've since been joined by Councilor Baker.
Can you just, and again, I apologize for late if you already went through this. Can you just update me on where you are with your office? Like what, and again, apologize if you just went through this whole thing. Did we just go through the whole thing?
No, but maybe you could just sort of give us an overview and give those viewing from home or online an overview of what your office does. And I'd also be interested in, with the changes in the 311 app or the adding of recovery services, sort of walk us through that as well, what that looks like to a user.
Sure. So since the onset of the office, we've been working on building a lot of partnerships that really haven't existed in the city as it relates to recovery services across city departments and across neighborhoods and other, businesses and really city departments focusing on that, focusing on the work with first responders and some of the more acute work first. We've done, there's so much, actually. I'm like, so let me think of three key things. One is increasing access to care. So that's been a main focus, increasing access to care. What we've done, as you might know, and we'll talk about next week as well at the budget hearing, is the 311 initiative, which is working with 311 so that, when I came into the office, and even with my previous role at the state, people in communities still don't know what to do and where to go for help. That is a consistent theme that was there when I came into this position, and that was one of the things that we looked to fix. We thought that 311 was a natural place to do that. Certainly, we need to build sort of the structure behind 311 because that's not their role, but use that as a mechanism so that 311 is an easy number to remember.
Mm-hmm.
We have built sort of a response, and we've been fortunate to get the approval for next year to hire the staff. We've actually already started doing that. And so that will be one big change that has the ability to be 24/7. I don't know of any other that are like it across the state. Not even the state helpline is 24/7. The state's helpline has partnered, with us. They're helping us out with this. So that's one, main focus is just, and then we obviously need to roll that communication out to folks that you can call the city's 311 number for questions. Also, there's been a lot of work with public safety. So the Office of Public Safety and also our first responder and public safety partners, Boston Fire, police, EMS. So there's a variety of things happening there that the office has been focused on.
Are you talking about the drug squad's new squad where if they find someone in possession or just overdose, they, instead of bringing them to jail, they're bringing them someplace?
That's sort of one piece that the commissioner started sort of at the same time, that a little bit after the Office of Recovery Services. I think they got off the ground, around the first of the year. But also really so much more around building communication and partnership. So there are community service officers that we've been going out and meeting with and making sure that they know about where they can get help and where they can send people. There's we have created a resource card with information on support for families. So not everybody is ready for treatment, and not everyone is going to, call up and want treatment. But there's support, and then there's access to treatment and harm reduction. That's the first time that that's ever happened. I mean, that it seems small, but quite frankly, it's huge. To have police, willing and able, and understanding that this is sort of a different time. The conversation is different, and the conversation is changing. That's the exciting stuff. Again, the Boston Fire Department has been so supportive of the Office of Recovery Services. They have sort of partnered with us, really with me from day one, on initiatives that haven't even rolled out yet that we hope to roll out in the future. But the first being the Faith Conference that I know some of you attended, around the goal of that to get information to folks that don't normally hear. We're in our world, and so we know all this because we work together and providers work together, and but as I say, sort of residents and the public, they're not in our world. They don't know our language, and so really a lot around that, trying to increase the access and awareness.
So is there in that whole the card that you have that explains some of the services? What I find is a lot of families that are new to this. Unfortunate for them, there are a lot of families that aren't new to it. The families that are new to it, the mothers, the brothers, they don't know how to handle. They don't know what to expect when it comes to dealing with an addict that's living in their house or that's kind of around when they're around. Are we looking at ways to support those families, the affected mother, the affected father that are dealing with the addicts?
Yes, I mean, we have our first Learn to Cope meeting, which is the Joanne Peterson. It's a national model, but it started in Massachusetts.
Joanne from Bridgewater?
Yes. So the first Boston Learn to Cope meeting started in November at the IBW, Thursday nights. That's the place we want families to go. That room should be standing room only with the epidemic that's going on. It has not been. There's a good group that goes. We think that there is a place for that in other neighborhoods, maybe West Roxbury, they're not going to maybe cross over, but we started in the space that we got, and it's been very successful, and we're working out, there's some people that don't want to lose their parking space, so they're not coming to the meeting. Well, we're going to go and get them, and we will bring them to the meeting. So certainly I think Learn to Cope is one of the best
So that
models.
sounds like an Al-Anon type meeting. What would the difference be?
Yeah, it's peer-led by parents who have kids that are struggling or have lost family members or youth, and so it's sort of a peer-led model, and it gives information on what to look for, how to support, how to Section 35, how to get your loved one into treatment, whatever is needed. It's a highly successful group. We also have community outpatient providers that provide support groups and do a lot of the resources that Jen mentioned. And actually Helen is out in communities providing information and tools to folks. So, that is just a consistent goal, and it's, sort of takes a lot of time, but that's sort of what we're trying to organize as well. And then we've also really tried to reduce the stigma, raise awareness and reduce the stigma. We have some great partnerships with sort of non-traditional venues. We're working with, we were the recipient of the Artisan Resident grant, so we have LaMarcia Frazier, who's working with women in recovery. We're doing, stuff around recovery and yoga, and really trying to broaden the scope of the continuum. So I mentioned earlier, you missed it, but focusing on a prevention strategy in the upcoming year. And having some commitments already so that we can move forward
And
with
can
that.
you talk about that a little bit, the prevention strategy? So that's talking to younger kids. Where is that happening in our schools? the prevention strategy?
What I spoke to earlier was that.
Sorry, I was late.
It's okay. Well, the office is in the next sort of phase, like starting now, moving forward.
Yeah.
As you know, the Blue Cross Blue Shield report didn't, purposely did not include prevention because the scope was so large. So we, are excited to move forward on developing a prevention citywide strategy, which, has not been done before in the way that we're talking about, and the way that we've done sort of the blueprint for the Office of Recovery Services. So folks like Helen and the other community coalitions, DSAC, Dorchester, there are some pockets of that right now. Their scope is generally the funding that they're getting is direct, their needs assessment to their community, and the funding that they're getting direct sort of what they're doing. They're doing a great job. We need that across the city, and each neighborhood is different. And so each neighborhood's needs and their scope will be different depending on what's going on with them. So we'll be embarking upon that process moving forward. So that's, an exciting sort of moving forward piece that we're doing.
I just have one more question, and whoever can answer, it might be you, Brendan, being the policy wonk that you are. Can you talk a little bit about the legislation that happens when it comes to detox beds? Are we moving away from the spin drive 5 to 7 days to more of a longer term, 14 days, 30 days?
Yeah. Yeah.
I wanted to hear what.
And are there any detox providers actually?
Well,
Bills here, but yes, in October, the legislation went into effect this past October that acute care doesn't need to go through the same pre-approval process that they did in the past, so that they can bring someone in and they can keep them for 7 days, go back and get the approval and keep them up to 14, I believe.
So we're not mandating that people will stay for 14 days. You need to do the 7 and then reapply for another 7?
Well, and be assessed, and if they need more, then the legislation is there to protect them. And again, those length of stays were insurance driven, so the legislation was a way to extend that. Fred?
Well, I just want to add, I'm not sure exactly how it's working. That's not my, but originally the legislation was that a licensed social worker or a licensed clinician could mandate the person into treatment for 14 days. The insurance company would have a right to review it after 7, but they didn't have the right to throw them out. But one caution that was thrown in there is, prior to that law changing, the detox, I think average stay in a detox was 5 days. So now if you put people in there and they take all 14 days, you're going to have no treatment beds available.
Or you could argue it the other way, the 14 days is more effective, and those reoccurring people maybe would stay out of there.
Well, again, you're cutting your access, and the whole goal was to increase access.
I think that's a slippery slope.
So
honestly.
I don't think that, I don't know that, again, that how it's worked out, but it was a consideration, I know, in the opiate work group.
Thank you.
Well, I was at a community meeting earlier this week, and Councilor Baker was there as well, and someone had suggested that we've been doing the same thing for a long time and it's not working, so perhaps it's time to try it a different way. And I think, with residents becoming more and more comfortable using the 311 app or calling 311, that's another point. I'm very excited about that sort of change in the way we do things and connecting our residents with services, as opposed to, we get so many phone calls in all of our offices, but sort of giving this other possible entry point to folks that are already maybe comfortable using that 311 app for other things, whether, whatever city service they need, this is another city service. I'd like to recognize Councilor Presley has joined us. I'm not sure, Councilor, if you've got questions before we move on to our next panel.
Oh, okay. Is that all right?
Oh, yeah, absolutely.
Okay,
yeah.
great. Thank you all. And like Councilor Baker, we're both getting a demerits for tardiness, so my apologies. And I don't want to ask too many questions and prompt you to be too repetitive, so I will watch what I missed. But first, I just wanted to send a message to those that are battling, those in recovery, and to the advocates, if you ever question for a moment, are people hearing our cry? Does government care, and are they going to do anything? not only do you have a commitment by this mayor and by this council, I just want to specifically champion the steadfast advocacy of Councilor Linehan, Councilor Baker, and now Councilor Asabi George. We're all allies in this, but we sort of bring our own individual heart's work to this body and a specific focus, and they have been incredible, and I just wanted to acknowledge that. And then I just wanted to ask some questions. I do a great deal of work in the trauma space and trauma recovery, specifically in the wake of homicide, domestic violence, sexual assault, and I can just say, like all of us who have been touched by a loved one battling addiction, my father battled a heroin addiction for a number of years, and it was only once getting incarcerated that he was actually able to get sober, which is criminal in and of itself. But sometimes there's such an emphasis on, one person, but we know that it devastates and destabilizes everyone connected to that person. We see that for surviving loved ones who've lost people to homicide or who have been witnessed or exposed to domestic violence, et cetera. So I wanted to just speak to that trauma recovery aspect, not just in supporting the single person battling the disease, but what are we doing? What is our commitment to offer those wraparound supports? I find with gun violence or a gang affiliation, we've had to have targeted efforts to support the family and in particular their siblings because they're more predisposed to commit violent crimes because of what they've been exposed to through their siblings. So that's really what I wanted to know about, was just sort of the family stabilization and recovery piece for everyone, not just the individual who's been battling the disease.
I'd be happy to respond to that.
Okay.
Jen Irby-Leggett from the Leggett Group in Rosendale. So my private group therapy practice offers a number of those types of services. We do a tremendous amount of trauma-informed treatment at the outpatient level. We see families who've been affected by gun violence, homicide, opiate addiction, and I feel like my earlier comments were talking about the eroding number of seats for therapy of that kind. Every time I see a family that manages to match insurance and availability of provider and get into our practice, I just sort of want to cheer because it's hard for all of those families to get those services. At my level of care, which is insurance-based outpatient therapy, the tectonic plates are moving and the seats are not available enough. There's lots of wonderful nonprofits that provide those services, and the type of service that some families need in terms of that lovely space to have family therapy, to recover, to do trauma-informed care. It's available for some with better insurances, and the number of seats available for families with the not so good insurances or public insurances are not enough, and they're dwindling. So that's my call to arms, is concern about that. And
so let me just ask the question, because one of the things, and I do want to again acknowledge the leadership of our council president in establishing this committee, which Councilor Asabi George chairs. But what I think is great about this hearing is it is an opportunity for us to kind of do our own internal audit or assessment. I just wonder, is there any sort of mapping that we're doing of what services are available? Because that's one of the biggest struggles for us in our seats is, how to connect people. So, do we have an actual inventory or mapping of how many services are available that specifically support families, beyond just sort of a link like, this one umbrella support group organization that exists statewide? Is there actually like a mapping and an inventory?
Yes, so we have the luxury of being a new office along with several other new offices, including the Mayor's Public Safety Office, the new Resilience Initiative with the Tia Martin, the CEASE Initiative with focusing on human trafficking.
Okay.
So what we've done is since we're all sort of new offices, we've got a working group together to discuss ways that we can, because we're all essentially dealing with similar populations, vulnerable populations. So there's also an Office of Returning Citizens, which is starting up. So we've been working with them in a working group. But what we've done is we're partnering with Root Cause as well to do sort of a a citywide assessment of reentry services, of services for vulnerable
Okay.
populations.
Excellent. Okay.
So we're all at the table.
So I came late. I don't want to take you too
Yeah,
far.
no worries,
Now I
no
just want to say to the council here. Now you see what it is when you're the timekeeper.
Yeah.
Okay. So one more. Thank you for that. So that work is ongoing. That is the point. You recognize there's a need to do that. Love that you're working across silos. My final question is if in fact 11% of the population of the city of Boston is suffering from a substance abuse disorder of some sort, can you just tell me a dollar amount? How much money is currently being dedicated to that 11% of our population by the city of Boston?
It seems like we may not know the answer,
to
but
go
that's
back,
something
yeah.
that we should actively seek out.
And
Okay.
just for clarification, when you say by the city of Boston, do you mean the city's
The city,
budget?
yes, the
The
city's
Public Health
budget.
Commission?
Yes.
Not our.
Yes,
partners here,
the
Public
city's
Health.
budget,
Yeah,
yes.
we can
Okay,
get that to you.
okay,
That might be
excellent.
great for our budget hearing
So
with you.
next week.
Okay, great. Thank you so much. Appreciate it. And thank you, Madam.
Thank you all. And that was an
Chair.
inside joke as a former BPS teacher, to have the opportunity to question the superintendent of schools at all has been very exciting for me. So I've indulged all of my colleagues with loads of what I think are excellent questions.
They are.
So thank you. So I thank you all very much for participating in this panel. You're certainly welcome to stay for the rest, but I do appreciate your time today as we move to panel 2, which includes Bill Sprague, Sarah Porter, and Patrick Hayes.
Thank you. Thank you. Thank you. Thank you. Thank you.
Thank you all so much for joining us this afternoon. If I think we'll start with Bill. If you could just introduce yourself and tell us about your work.
Happy to. Thank you for the opportunity, Counselor. Good afternoon. My name is Bill Sprague, and I'm the President and CEO of Bay Cove Human Services. Bay Cove is a multi-service agency providing a wide range of services to persons challenged by mental illness, addictions, developmental disabilities, and the effects of aging. My testimony this afternoon is focused on our services to people with substance abuse issues, and I'll separate it into 2 segments. First is our services specifically designed to treat people who are actively working to discontinue their dependence on alcohol or drugs. The second are services that we provide that are targeted to address mental illness and or homelessness, but serve people who are actively using drugs or alcohol, but not yet ready or willing to begin working on their recovery. In these programs, we're providing harm reduction rather than active treatment. Our Addiction Services Division provides a continuum of care in and around Boston through both outpatient and residential models. At our Canal Street location near North Station, where my office is, we offer methadone treatment and counseling on an outpatient basis to approximately 370 individuals. Some come in on a daily basis for dosing. Others have earned take-home doses and may come in every few days or weekly. All treatment center clients participate in weekly group and individual counseling. Our residential treatment continuum begins with our Andrew House Detox, which was Bay Cove's first program established in 1974. Andrew House was a 60-bed detox operating on Long Island that had to close when the bridge was closed. We currently operate 24 beds at the Shattuck Hospital on a temporary basis while we work to reopen the full 60 beds at a new location in Boston. Detox services are generally 5 to 7 days and are covered by insurance. For many of the people that we serve, that insurer is Mass Health. The next step in recovery that Bay Cove offers is Transitional Support Services, or TSS, which is a 30 to 45-day service paid for directly by DPH. Our TSS program is located in Weymouth, but has historically served primarily Boston residents. We also offer a number of recovery homes for clients, many of whom have completed TSS. Our homes for men and women are located in Cambridge and Somerville and serve people throughout the greater Boston area. Bay Cove also operates the Boston Night Center, the Cardinal Madeira Center, and the Bayview Inn, among other programs, which serve homeless individuals in Boston. As we well know, many people who are homeless also struggle with substance use and abuse issues. These services are not designed to treat the addiction, but do keep people safer and offer us the opportunity to intervene and encourage individuals to engage in treatment by entering detox or another addiction treatment modality. We're all well aware of the heroin epidemic in our Commonwealth, and the need for services often exceeds the supply. The impact on our community resulting from this crisis has been devastating in many, many ways. The state is looking to increase treatment capacity, which I'm sure we all support, and as providers, we're ready to respond. In doing so, we face a couple of significant challenges. First, identifying appropriate facilities to deliver the service in a Boston real estate market that is extremely challenging for not-for-profit entities. Second is locating the services that everyone sees as needed, but many would prefer be located somewhere else. Private providers need the help and support of our elected officials as we meet these challenges. We all need to work together to impact the stigma associated with addiction and other behavioral health issues. We all need to work together to support the people who are doing the incredibly difficult work necessary to start and stay in recovery. We all need to work together to recognize that different treatment interventions work for different people. Finally, we all need to support alternatives that can be successful for all individuals who come to us for help, whether it be abstinence, harm reduction, AANA, medication-assisted treatment, etc. There is room and need for all of the options that we can offer. Thank you.
Thank you very much, Bill. Sarah?
Hi, my name is Sarah Porter. I'm the Vice President and Chief Operating Officer at Victory Programs. Victory Programs has been providing addiction treatment services in Greater Boston for over 40 years. From the first program, Victory House on Mass Ave in the South End, that welcomed vets struggling to heal and reclaim their lives, Victory Programs set on a path of providing services to those whom more traditional settings have proven difficult. Throughout our history, Victory Programs has reduced barriers to access and provided innovative and culturally competent services to historically underserved individuals and their families affected by substance use disorders. Today, Victory Programs operates two short-term stabilization programs, 3 residential recovery homes, and a family sober living program within the city of Boston, open to individuals from across the state. Additionally, we provide prevention services, including overdose prevention and naloxone distribution in the rest of our programs, including 2 family shelters, 5 permanent housing sites, and the Boston Living Center. These prevention services are also available throughout the community. Victory Programs also had a program located on Long Island. Jolene's family home opened in 2007 and served hundreds upon hundreds of women before it was closed unexpectedly in 2014. With several hours' notice, 47 treatment beds for women in the state of Massachusetts and the city of Boston disappeared. We've spent countless hours working to regain those beds for the women of Boston. This past February, 10 of those beds opened as we expanded our New Victories program in Dorchester. We're on track to add an additional 31 beds for women in Boston before the end of the year. 24 of these beds will be located in a new location currently undergoing renovation in Roxbury. Relocating a recovery home is anything but easy. We've visited every neighborhood group surrounding the area, hosted information sessions in the building, met with countless neighbors individually, all in an attempt to be transparent, involved, and supportive neighbors. Both Councilor Presley and Jackson deserve special recognition for their support and assistance during this particular process. Last year, Victory Programs served nearly 700 women in our addiction treatment services. Our programs operate at nearly full capacity every single day. Waitlists for residential recovery average between 4 and 6 weeks for women in particular. Our transitional support services program, Women's Hope, that also functions at the Shattuck Hospital, provides on average 28 days of stabilization services between detox and longer-term treatment. That program receives approximately 28 to 32 referrals a day. Massachusetts is in the midst of an opioid epidemic, as we all know. Well over half of the individuals accessing treatment through Victory Programs last year indicated that their primary addiction was opioid-based. The need for detox services is great. For nearly everyone, detox is the very first step in the long journey to recovery. Based on the nature of addiction, it's a step many need to take multiple times. Victory Programs is committed to accompanying people throughout that journey, but with such limited detox services in the city of Boston, it's nearly impossible to get people started on their journey at times. We strongly support Bay Cove's efforts to recite the Andrew House Detox. As fellow addiction providers, we know the life-saving impact these services will have, and as fellow Dorchester neighbors, we know the positive impact that an aware and responsive organization can have on the communities where it operates. We look forward to the city's continued support of addiction treatment services for all who desperately need them. Thank you.
Thank you, Sarah. Pat?
I'm Patrick Hayes. I work for the Boston Fire Department and Firefighters Local 718 Employees Assistance Program. Our primary function is to assist Boston firefighters and their family members with a variety of issues. Substance abuse seems to be the predominant one. We also represent members of the PFFM, the Professional Firefighters in Massachusetts, and we make referrals and do some in-house counseling for substance abuse issues. One of the issues I'm here for, or the reason I'm here for, is the project they started last year in November called Faith. What was happening was we had several fire companies that were responding to the same addresses. One company responded to the same address in East Boston 3 times for Narcan and overdose. And so the commissioner of the Boston Fire Department, Joe Finn, and the president of Local 718, Rich Parrish, wanted to get some type of outreach program for these members of the citizens of Boston to give them some help. So we started the Faith program, and that objective was to just bring information to, at first, just to Boston firefighters in the offices that were responding to these incidents. So when they showed up at an incident, if there was a family member there or someone was there, we had a packet for them, and you could hand that over to the individual family member, and it explained, it had learn to cope, it had a variety of things, how to get into detox, how to do Section 35 through the courts if your family member was unwilling to go into treatment, and that's how it started. And just last week, we had a member was brought to Meeting House Hill in Dorchester. Her son had overdosed in the car. The people from Meeting House Hill Narcaned him, and the lieutenant there was able to get that individual into detox the next day. The mother called because of the program to educate our members, to be able to educate people out in the field where to go for help. And the issue is bed availability, but it's also getting access to the beds. That's the stigma. That's the problem that people are having a lot. And we get a lot of calls from other agencies in the city and in the state that are having a hard time accessing health care or substance abuse care or mental health disabilities or stress issues. And we help them navigate because it can be complicated. And the social worker that was here earlier, Jen with one end, was talking about you know, the growing, the shrinking financial aspect of it. And as a Boston firefighter, remember Local 718, we were faced with this also. If you looked at our inpatient residential program, we would get 5 days for a detox, and we would get 3 days for mental health screening. After the marathon bombing, we met with then Mayor Menino's chief of staff, Mike Kenevi, and a few of the other staff people, and we were able to contact Harvard Pilgrim, and they brought in United Behavioral Health, who handle their substance abuse and stress, mental health, to their contract provider. And they will allow us to get 28 days in programs, but they're out of state. So that's one of the problems here. Like the 14 days that the council was talking about, these are the things that we're trying to overcome also. And the Faith program that we launched, unfortunately, we can only get you 14 days, and that's if you're willing to go. But that's why I'm here. Yes.
Thank you so much. Thanks, Patrick. I'd like to recognize that we've been joined by Counselor Tito Jackson as well. One of my questions for the three of you, and anyone, please feel to respond, but based on some of Bill's comments, was the talk of the continuum of care. Can you walk me through some of the typical, and I understand that every individual's care and path to recovery is very unique, but can you walk me through some of the typical steps that an individual may go through?
Sure. Our services are set up in anticipation of just the continuum that you were asking about, and and they are services of increasing length, but also that, look at, in detox, our detox is primarily a medical detox. We're working with people to get through the physical withdrawal and the physical components of discontinuing drug use. But we know that statistically that's not going to be sufficient for the vast majority of people to stay in recovery. So the next step, the TSS that we run, that Sarah runs, is really works with people over an extended period of time to deal with issues related to why they've used drugs, and what kinds of changes they need to make in their life to support a life without drugs. To often work with people who have began using drugs in a self-medicating strategy, and to deal with the underlying mental health issues that may present once the drugs aren't masking them, any of a range of things. And then we run recovery homes that are generally 6 months in length. All of our homes are designed to help people work, so everybody's expected to work or be looking for work, because as Fred discussed in the earlier panel, people's ability to move on after they're in a program, whether it's onto sober housing, back with a family, or into an apartment of their own, is certainly dependent on them having a source of income. So we want them to get established with that while they're in the recovery home. We also offer outpatient services, and our methadone treatment center serves 370 people. Some of them are not working, and those are the ones that often get the attention because they don't necessarily have a place to go after treatment. But the vast majority are stopping in for medication or counseling on their way to work, or after work, or on their lunch hour. And we see them very, very briefly, and that allows us to support them in a lifestyle that probably most of their coworkers and neighbors are unaware of.
What about the challenge of being prescribed a certain type of treatment or a certain service dependent on your health insurance versus the type of care that you need in order to be successful with your recovery? I'm sure that you're all facing some of that.
The majority of the work that we do is with people who are on Mass Health or one of the carve-outs. So that's a more standardized coverage than the commercial insurers. We've struggled particularly with Blue Cross in methadone treatment because while it's a daily dosage, up until recently or sort of now, they've done a copay for every dose. Well, that basically makes it a cost-prohibitive service that people covered by Blue Cross can't really access. It's a coverage in name only. We believe and have received some assurances that that's going to change. But insurance coverage is often an issue. Yes.
But can I add to that? I think at least two of the components, as Bill laid out, that continuum, are funded by Department of Public Health through the state of Massachusetts. So they're not dependent on insurance at all. So the entire continuum can function sort of in a little bit of a different way depending on people's access to insurance.
Yeah, right now, the insurance only covers what's termed medically necessary. So those would be the initial days in detox that have been 5 to 7. Councilor Baker pointed out the important change in legislation that would allow that to continue for up to 14. But services after that are not currently covered by insurance.
Right, until you end up at the end where people may attempt to access outpatient services, which is what Jen with one N was talking about in terms of access to outpatient services.
Right. And Patrick, any with your work in particular with our insurance companies that are offered in the city of Boston, what do you see as the greatest challenge? I think you articulated a little bit, but.
Well, I think the insurance is one of the major issues. When we were brought in for a hearing, they discussed the program, but they only allowed, it was myself, he's retired now, Lieutenant Brian Fleming from the police department, and Lieutenant Jenny Famigliari from Boston. And yes, we were brought in after the marathon bombing. And the access to these two 28-day out-of-state programs in Pennsylvania were only authorized for the first responders who had dealt with that marathon bombing. So it's not an option for custodians and teachers. It's not open for all city employees yet. So that's what we look at. But even we have the same issue. Like, some people don't want to go out of state for 28 days. So if we can get you into a facility for 5 to 14 days, if we're lucky, if the insurance will carry it that long, then we'll do an intensive outpatient IOP. That could be 2 to 4 weeks, and we use different facilities depending on where you live to get that done. And then that's the end of it. So if you have someone who's had an addiction for 6 years, it's rather difficult to wrap it up in 6 weeks.
Thank you very much. Councilor Linehan.
Thank you, Madam Chair, and thank each of you for what you do on behalf of our city. As I said earlier, for me, it's about resources. And if you could touch on if you had additional resources, what to apply to them, how big of an issue it is to address capacity, and then if you could give me ballpark dollar amounts of, like, how can we truly address this issue? And I'm talking Boston specific. Truly, that we don't take care of our 19,000 employees is an issue if they're struggling. And one question there would be, they say 11% of folks in the city of Boston or in the state have substance abuse issues. Does that run true in the fire department?
I would say yes.
Could it be greater?
It could be, yes. But there's degrees to the addiction.
No, I understand.
So, but yes, it could be, easily.
Okay. And so on resources, either one of you.
Sure. I think I'll echo what Bill already said. With all the resources in the world, I still have to have a place to provide services. And so when we began the process of resiting our women's recovery home that was on Long Island, we competed in the private real estate market. We were competing to purchase property. We all know what the real estate market looks like in Boston. So you're paying an exorbitant amount of money either for rent or to purchase a property that you then have to rehab to make into a place that can function the way you need to, and you have to deal with siting. So I currently have, we opened 10 new beds in Dorchester right outside of Upham's Corner. We're attempting to take that to 14, but it's probably going to take another, by the time it's done, probably 6 to 8 months to go through the zoning process, to get through kind of the inspection, the denial, the zoning board of appeals, the hearing, getting the neighborhood association kind of support meeting in all those different places. It's months upon months upon months of work, assuming it goes well. If it doesn't go well, then it looks very different.
No, we've all been right in the middle of all of that, my 9 years, and trying to navigate and carve out space. And I've been on both sides of the issue and fighting, and it is clearly it's a difficult task to cite. And so how would, other than the practical, what can the city do? Like, I mean, if it's so hard to deal in a real estate market, or if it's so hard and we've lost all of that space out at Long Island that was our own property, and what kind of money would you need to help do some of this stuff,
I think the money is a moving target. I think, the
But
real estate market.
Are we talking $150,000? Are we talking $20 million?
The governor's budget is going to add 200 new beds in the state, which are certainly well needed. More are needed than that.
How much is that?
A recovery house bed is $100 a day, right? $100 a day per person. So
$6 million.
Right.
I did the math.
I'm very impressed, sir. It's interesting. We were looking at opening a program that's outside of the city, but I think the issue remains the same. And a colleague who ran a service not too far away approached me and said, "I'd really like you to reconsider." And it was sort of a, a competition kind of thing. And it was, and I questioned him, and he said, it has nothing to do with being able to keep our beds filled. That will be a piece of cake. I don't know where we're going to find staff.
Yeah.
And so staffing is
Staff.
is an ongoing issue. We compete, for nurses with an incredible hospital system in Boston that has resources well beyond ours. That's a constant, constant challenge. We all know the demographics and the needs identified for Massachusetts, for particularly human services for the years to come. We're constantly going to be struggling. We lose people to the school systems and the hospital systems on a regular basis.
So I'll ask one more time. So if specifically, if you had some money, what would you use it for? Let's say a couple of $1 million.
I would treat more people. I would
Yeah, but
have.
how would you?
I would purchase or rent additional space. I would build it out to be appropriate. I would go through the zoning process to get it set up the way it needs to be set up. I would work with the community representatives to get neighborhood support.
I understand. So that's what you would do. You would.
Well, yeah, and then I would, and then you move on from that.
Is there a capacity? Are there enough people waiting in line to get in?
Oh, absolutely, without
For
a doubt.
$2 million just for you, you could spend that.
I'll give it a shot. Yeah.
The system, sure.
Could you spend $2 million?
Oh.
So if I gave you two and I gave you two, can you spend $2 million?
We'll spend it.
And the fire department programming, additional outreach, $100,000 maybe could help you do some stuff.
If I-
Augment the lack of insurance coverage. You could use some more money, right?
Yeah, or we could renegotiate with the insurance company, as she was saying earlier.
Yeah, let's hope we get to do that.
The current system.
was-
I'm sorry.
No, I mean, that was clear to all of us, that early on that is an issue that we probably collectively have to address. I don't mean to just focus on the one thing, but one of the issues is we talk about programs, we talk about the need, we talk about the difficulties, but we rarely ever come up with the dollar amount, And if 200 bed, we had 1,500 people die in Massachusetts last year. Die, right?
Mm-hmm.
I don't know how many are in recovery. 5,000? Maybe?
I mean, we mostly
do
see
this
people
again next year-
in those first stages of recovery. There are, thousands of people who are in latter stages of recovery that are outside of our system. One of the challenges for beds is that each step in the recovery is a longer stay, and that creates a bottleneck. People are coming out of detox on average every 6 or 7 days, going into programs that, people stay in for 30 to 45 days, where people are going into the next step for 6 months. So each step, the demand and the bottleneck for beds grows. So I would concur with Sarah.
All right, thank you.
Thank you.
Thank you so much. Councilor McCarthy.
Thank you very much, Madam Chair. Sorry I had to step out there. It's budget season. It's crazy. I know that Councilor Linehan had briefly talked about Long Island, and I don't want to reinvent the wheel, but how many beds did we have out there when it was?
How many treatment beds?
Yeah.
Because there were a lot of shelter beds out there as
Yeah.
well. We had 60 detox beds.
60 detox beds, and there was like 400, was it 400 shelter beds? Is that about right?
Yes.
So has there ever been any thought of having that? I know that the bridge is gone. It should have been gone 10 years ago. If anybody ever drove over it, you'd know.
I drove over it regularly.
Yeah, I'm sure you did.
I put my windows down.
I'm sure you wear your little wingies when you're driving over just in case. Has there been any talk about or the possibility of turning that over to a private? Because we continue, as Jen said, and my good friend Dan O'Connor's up there. We talk about 28 days might be the magic number, although there's no magic number. But 28 days of treatment is certainly better than 7, and a long term. Then you wouldn't have to have the constant over. You could do boats and different. We could figure out how to get people over there. Has there been any talk about privatizing that or getting somebody in there who could actually utilize it? Because now it's a shell of a building when we need it the most.
Yes, a shell of 2 buildings with a lot of our renovations in them. There was a great deal of talk about that initially after the bridge closed, whether or not we could continue the services out there. with a different system of transportation, and it was determined that that really wasn't feasible for a couple of reasons. One was the frequency of the boats that were going to be needed, not for getting people on and off every 28 days or 5 days or whatever, but that we staff 3 shifts a day. And so that was, one piece of it. The second piece was the cost because of the medical frailty of the people that we served, the need to access hospital services on an unplanned basis and the cost that would be associated with that. And then the third, which was a logistical thing that's probably solvable, is there wasn't a way to make it accessible for people in wheelchairs, and the Department of Public Health would not license any inaccessible site.
I can add to that too. We had 47 residential recovery beds on the island, so the other end of the spectrum from detox. So we were working with individuals who were re-engaging back in the community. So they were looking for jobs, they were reconnecting, reuniting with their families, they were looking for housing. So the same thing in terms of the access they would need to the mainland coming and going. It would have been very difficult for those individuals to sort of heal and recover and re-engage in community life the way they needed to based on a boat schedule.
So those were the stumbling blocks at that point.
Yeah. Okay. Thank you very much. Thank you.
Thank you so much. Counselor Baker.
Thank you. Can we talk about methadone a little bit? Is it true that if you're coming into a detox, is everybody, do they have a choice? I want to go cold turkey or I want to use replacement?
So methadone is used in a detox facility as a medication to help people in those first few days. It's not the start of a methadone maintenance program. So people don't leave detox with a continuing prescription of a methadone necessarily. Methadone is used, like Librium was used for people who were detoxing from alcohol. It was a medication to help them through those initial days.
So at what point does that person decide to stay on methadone? Or is that decision made for them? I'm saying, does that person go in and do they have the choice to say, I want to go the methadone route, I don't want to go the methadone route?
Sure. As I said, we want to offer all of the different treatment options to people because different treatment options work for different folks. Some people prefer not to use medication. Some people's lives have been saved by medication. Some people go on a methadone treatment program and will wean themselves off of it. And some people will move just to a very, very low dosage and stay on that dosage for an indefinite period of time.
Now, is it true that if you're on methadone, and I visited Topeka Street, and they said that if someone coming in that's on a daily treatment, if they're using something else, they don't take away that methadone treatment. They just kind of say, well, you shouldn't do that and continue that. Like, so people can use heroin and methadone at the same time. It's not like you get, like before 70s, 80s, I remember people that I knew that were on methadone. If you went into your clinic and they tested you and you were using heroin or anything else, you got cut off your methadone. Is that still the truth, or?
I think different programs have different policies around that, and certainly some programs I think still would follow that policy. Other programs would perhaps give somebody a second chance. I don't know of programs that would allow you to continue to use drugs and continue to use and continue to be part of the methadone program. We test people on a regular, although not how do I say frequently, but not regularly, so they can't anticipate it.
Every other month, or
more frequently than that.
So if someone comes in and you find heroin in their system, twice in a row, they cut off their methadone in Bay Cove. This is what Bay Cove
We would
does.
need people to seek a different form of treatment because this one wasn't working for them.
Okay. So my issue that I have, constantly talking about this, and I'm stuck on the 5 to 7 days. It doesn't work. And we're talking about bottlenecks. It's bottleneck because the 5 to 7 days, it looks to me like we're having the same people cycle in and out. You may go out, you're 5 days, then you're okay for 10 days after that, then you're back in another detox someplace. I believe that until we change that to 30 days, I think we're going to keep continuing to spin our wheels. And it seems like we run the risk of this industry becoming an industry and becoming more about money than people actually getting help. If you read in the Globe yesterday, 200 bed facility being built by foreign investor money so those foreign investors can get green cards. That's scary to me. Bain Capital owns the methadone clinics. That's scary to me. I think that people that do the work, your heart is in the right place, but I personally think we're spinning our wheels. I think until we start having real conversations about detox facilities that people can't say, you know what, I'm ready to go home, I want to go home. Until we can say to them, you signed here, you need to stay here for 28 or 30 days, we're going to continue this conversation till I'm dead. So, and just for, you had talked about Bill's facility coming to Dorchester and hope we have support. I'm on record of not supporting Bill's facility because it's 60 beds coming into a pretty crowded area. District 3 has taken all the homeless shelters. We've taken Hello House. Now we're going to take the 60-bed detox. And I'm not anti-recovery by any stretch of the imagination. My father's been sober for 52 years. And part of my problem here is the business that's surrounding this whole industry now. And I'm calling it an industry because that's what it's becoming. If my father decided 50 years ago to put alcohol down and pick up cough syrup as something that he was gonna keep him from the shakes or whatever else, he wouldn't be alive now. I might not be alive now. I just think the way we're treating is wrong, and until we make some serious changes in it, 30 days being one, and really looking at replacement therapy. And I know that's bad to say in most rooms that because replacement therapy is the way of the future. I just saw a big panel of doctors and specialists, and every one of them's replacement therapy, more methadone, and I don't agree with it. I think that and I could be wrong, but it seems like since this whole replacement therapy concept has taken hold, it seems like now our overdoses have gone through the roof, and there's just more and more people hooked. And is it replacement therapy? I don't know, but it doesn't seem like anybody's getting better. We have more and more people working on it, more and more money going into it, and very, very few people are getting better. So what I wanted to ask was if percentage-wise, in these 5 to 7 day detoxes, how many people are getting better? If 100 people walk in June, how many people are gonna be successful?
I think it will depend on how you measure success. We have a limited ability to track people indefinitely. We send from our detox about 2/3 of the people continue in another level of residential program. I couldn't agree with you more that 5 to 7 days is not going to cure anybody. And the system right now would be for a different type of program, and we literally drive the people from the detox to the next program because we want to make sure that people get there and get there clean and continue. For the folks that come out of TSS, we've followed up at roughly a 1-year follow-up, and about 50% of them are still clean.
50%.
So,
and how many people aren't going to TSS? How many people are doing the 7 days? Say, you know what, I'm good. I'm just gonna go on my own.
Our statistics are about 2/3 of the people go to a residential program, and between 15 and 20% go to an outpatient program. So about 80 to 85% of the people are going to some follow-up treatment post-detox.
Thank you.
Thank you. Councilor Presley.
Okay. Well, first, thank you all for what you do and for being here today. I just wanted to say, specifically regarding victory programs, your gratitude dinner is left an indelible impression on my heart. It's an event I look forward to every year, and I just appreciate what all of you do. And I just also wanted to just acknowledge that you can see people in your community hurting, and you could just go home and say a prayer for them, or just shake your head and say how sad that is. But, you know, the fact that 718 has stepped up and said we're going to take care of our own and support our families, you're to be commended for that. So I did want to just ask Bay Cove and Victory programs to specifically speak to not only the cultural competency aspect of this, but Jen, if you could speak, just revisit your numbers on the women's programming side, because, you know, in every space I'm in, I continue to hear about a disparity in both treatment beds and programming for women, in the same way that we recognize in human development, there's no one-size-fits-all approach to building up people. You know, and there certainly is, you know, there's no one-size-fits-all approach in healing them. And so I just wanted to speak more specifically to what our gender-specific focuses are. And then something I'm seeing a growing number of is pregnant addicted women, an increasing number of them that are homeless as well, and just wondering where they go and what do we have for them.
Yeah, so I'll start with the last piece. In terms of women who are pregnant are given priority across the state for accessing treatment. I assume that's at every level of care, right? And so they are immediately not only given access, but there's an expectation of, if you don't have space, that you're helping to find that woman find space of where it is they need to go. Everybody sort of echoes that idea of pregnant women needing in addition to
So that isn't
services.
centralized, like, oh, there's just 3 facilities that help pregnant women.
No.
Every provider.
Absolutely.
Okay.
Absolutely. There is centralized intake. If you're pregnant, there's a phone number that you can call that will sort of guarantee you access. It may not be immediate access, but you will immediately have access to a case manager who will sort of walk you through that process. So that has existed for a bit of time in terms of the heavy focus on pregnant women. In terms of female-specific services, we know that there are fewer, it takes a woman longer to come to treatment. And when they come to treatment, they tend to come with a bigger set of baggage behind them. There are issues of children. There are issues of sexual exploitation, of trafficking. There's a trauma. People have experienced a level of intensity in their addiction that it takes a good amount of time to sort of even begin to shake off, where do I start? Bill had talked a little bit about the stabilization services, those 28 days of service that happen between detox and a longer residential recovery process. And what we find is people tend to arrive after 5 to 7 days, and there is a level, they're still medically detoxing. They're awful shaky in some ways, but the idea of standing here for 28 days to figure out, what am I going to do next? Where am I going to go next? What makes sense in terms of, let me reconnect with Department of Children and Families, figure out where my kids are, what do I want to do about that? Let me figure out, where's my primary care physician? Basically sort of starting to examine, how would I begin to put my life back together? Having 28 days to do that in a somewhat committed process before going out and restarting kind of back in the community. We just recently launched the program we opened in Dorchester, adding 10 additional beds for women, is the first time we're operating a co-ed program. So we have 2 houses next to each other, a house for men and a house for women. And whereas we originally thought, okay, many of these services will happen together. Many of these groups or psychoeducational services will happen together. What we're finding is that they tend to function a little bit better for some people, most people, in that the women are looking for a place, their own house, their own place to be, where they're able to sort of get things back together.
Okay.
Add to that?
Just a couple of things to add, and our experience is very similar. At both of our detox and our TSS program, we run roughly, because we can flex it a little bit, but 40 male beds and 20 female beds out of the 60. So it's about a 2-to-1 ratio. And honestly, that's based on demand. I mean, we would run it at whatever. We do have a recovery house specifically for pregnant women, and it also women can stay there up until the baby turns 1. So it's an interesting mix of, I don't know how, many pregnant women should be in a house with watching somebody who just had a baby, because it's an interesting mix of what you're in for with babies waking up all night and everything. But it is a program specifically. One of the phenomena that we're aware of, and it does influence things a little bit, is the motivation for most of those women is different. These women didn't come to recovery because they were at a point where they absolutely wanted to get off of drugs. They came to recovery because that was the way to keep their kids.
Okay.
And it's a different motivation, and it does influence some of the work that we do. Their motivation is they want to keep their kid.
Okay. All right. So just in terms of the disparity point, is there really disparity in meeting the need, or is what you're providing comparable to what you believe the need to be?
Well, so I will say that when Long Island closed, we lost 76% of the female beds in the city of Boston. So that in itself took a huge cut off of that. I know in our residential recovery homes, I have about a 6-week wait for women's services, as opposed to maybe, depending on the day, about a 3-week wait for a men's program.
Okay, thank you. That's what I needed. Thank you so much.
One quick thing on the detox services. One of the elements of having the detox on the island is it did limit our ability to serve pregnant women because of concerns about having access later in pregnancy to medical treatment. So if we are successful in relocating the program, within the more traditional city limits, with greater access to hospitals, that would open up those detox services for pregnant women.
Thank you.
Thank you, Councilor Presley. Thank you all so much for joining us today and sharing with us your expertise. Patrick, before you go, would you be able to share with us the packet that your firefighters have or distribute? Because I'd be very interested to see.
I don't have one with.
No. You can get it to us when you can.
Yeah, I can. Yeah, you'll have it tomorrow.
Beautiful.
Okay.
Thank you so much. I appreciate that.
All right, yeah.
Thank you so much. So we're going to.
Counselor, do you want written?
Yeah, we'll take the written testimony as well. Thank you. And while they are preparing to leave, we'll start with our last panel with Michelle, Marianne, and John.
Thank you.
Thank you. Sarah, thank
Thank you. Thank you.
I don't think I have anyone for public testimony.
Thanks.
Oh, thank you, John. Thanks.
Thank you.
So Michelle, we'll start with you. Thank you so much for coming today.
Thank you. It's an honor to be here. So I'm a nurse, a coach, and a teacher, and I like to, when I present, put a little bit of background into why we do what we do by doing a little bit of teaching. I'm a certified addiction registered nurse. I've been doing this for 9 years in the field of medicated assisted treatment. So I've seen well over 1,000 patients in my time. I'm also a high school softball coach, so I bring a lot of experience working with youth, which unfortunately is now most of what my patients are. So just going to read a quick statement first before I go into it. We believe that drugs don't cause the addiction. It's a whole list of ingredients that creates the problem. Drugs, environment, genetics, and diet. Yes, sugar, because it lights up the same part of our brain as cocaine. We start newborns on formula at sometimes 12.5 grams of sugar per serving. Our diets have been pushed by the food industry and have primed our brains for addiction for the last 50 years. In 1950, the average American already consumed 40 pounds of sugar, and that number is now up to 100 pounds per sugar per year. It's embedded in everything we eat. And you can look at the obesity rates, which parallel the addiction rates. In 1970, 45% of the population was obese, and now it's 74%. Added to that is the instant gratification, more, bigger, better now attitude, and everyone gets the trophy habits of our American society. This, in our opinion, has been a combined recipe for the failures and for the reason we are losing our children. And I don't have to tell you that obviously Massachusetts is experiencing one of the worst situations. As a society, I believe we have to look at this not only as something that affects others, but all of us. It is a disease born of unhealthy habitual behavior, just like diabetes or high blood pressure. If we can take the negative and the stigma out of how we look at this, I believe we can create hope. When we have a diabetic come into our office, we don't kick them out when they have high blood sugars. We don't call them dirty, and we don't call them clean, and we don't call them food addicts. And that's what we're doing to our patients. And so we've taken all of this information and all that we know about neurobiology. And we've decided to take a different approach towards what we're doing. We have created a holistic, comprehensive treatment program that involves nurse care management. I work at Harbor Health Services. We have 4 community health centers throughout the Commonwealth. 2 of them are down on the South Shore, one in Hyannis and one in Plymouth. We also have the Geiger Gibson Community Health Center, which is the oldest community health center in the country. And we also operate out of the Neponset Health Center. What we have is a nurse-managed care program that allows nurses to manage both chronic pain and substance abuse patients, both obviously uncontrolled substances, so they take an extra level of monitoring. The nurses are able to see the patients very frequently, monitor them for, obviously, compliance for contracts and urine drug screens, but do a lot of patient education, support, and connection to community resources exactly the way we deal with the diabetic, because that person needs the same amount of care and the same amount of support. Polarizing these patients is not to us the way to be successful. Putting somebody in a box they can never get out of because we've placed that label on them doesn't create a whole lot of hope. So we kind of take a much different approach here. We work very closely with our medical providers and our behavioral health providers. We know how hard it is to get strong behavioral health support service in the community because of the billing issues as well. It's something we struggle with on a daily basis. But all of that is the same way you treat diabetes, which is why we take the approach that we do. Several, if not all, of the other community health centers have the same approach. They're all OBOT programs, office-based addiction treatment. All of them are using Suboxone and Vivitrol as well. Just like you'd use insulin, which is a medication-assisted treatment for diabetic. So I think that if we're all looking at this as a disease, that we should all probably try to start looking at how do we treat disease, and this is how you do it. We also do treat pregnancy, and we have immediate access for pregnant women as well. I just want to make sure I addressed that in case you had a question there. The medications that we do utilize are Suboxone and Vivitrol. We're seeing less and less people asking for Suboxone, and I believe that has something to do with the fact that there's so much fentanyl in the heroin, people having less success in actually stopping that heroin use the way they used to be able to with Suboxone. The Suboxone in the street, yes, it was out there years ago, and it was driving people into treatment because they were actually seeing they could become sober by using that medication. There's very less Suboxone on the street now because they're not being successful with it. Fentanyl can bump the Suboxone. Okay. The reason we're needing to use so much Narcan is because fentanyl is so much stronger. It takes 4 hits of Narcan in order to bump the fentanyl out of somebody's system. So people are actually using very little heroin because there's so much fentanyl in it. And that's another huge problem that we're having as a barrier to us getting patients to actually be successful in treatment. And I'm sure they're seeing this at some of the inpatient facilities as well. We have created a bridge to some of the correctional facilities where we're going in and doing nursing intakes and getting those patients, once they come out on day of release, right into our facilities to get Vivitrol shots right away. We have implemented protocols to make sure every patient in our facilities who has a controlled substance prescription is also prescribed Narcan, whether they need it for themselves or for a loved one, they have it in hand. We also now carry it in our pharmacies. We have 4 separate pharmacies in all of our facilities. For those of you who don't know, Vivitrol is a blocker, and it blocks both alcohol and opiate from actually getting that reward. So we're finding that more people are becoming more successful using that, and we're actually seeing a very big increase in people using alcohol. I think they're trying to avoid the alcohol, so we're seeing avoid the opioids, so we're seeing more people using alcohol. So we're seeing a big rise in that. We're doing a lot of teaching for both our providers using the scope of pain training out at Boston University. Our providers are constantly trying to learn more about and become more comfortable treating substance abuse, and I believe that's a huge barrier because there are not enough medical providers out in the community that are comfortable to treat substance abuse in their own offices where it's very simple to do. We need to get more education and more providers comfortable doing that. So that would be something I think that maybe the council could help with is getting more education out there for that. I believe that, if possible, funding more nurse care managed sustainable programs in the community health centers would certainly be helpful. I know that where we have the disparity in where we're paying the behavioral health patients, I know that you have a lot of detox facilities, sober homes and halfway homes doing a lot of urine drug screening that Mass Health is paying for at hundreds of dollars of a pop twice a week that they don't need to. They can use $20 Instacups and save some money to pay the behavioral health. So I think some oversight in where this money is getting spent in Mass Health, having done this for 9 years and watching this happen, I think that would help their efforts as well. And my personal and strongest recommendation is that we need better education in the schools starting from the 3rd and 4th grade. And not teaching fear, but teaching science. Children are smart at those ages, and they're concrete thinkers. Okay, putting a celebrity in a school gym and having that person stand up in front of them and tell them how many drugs that you use, but they're still standing and surviving, it's not necessarily the message you want to give to a 12-year-old, 13-year-old, 14-year-old who's just entering risk-taking behavior. So education, it's one of the reasons I'm already in the high schools doing just that. So I thank you for your time, and I applaud everyone's efforts. Thank you.
Thank you. John?
Yes. My name is John McGann. I am the president of Gavin Foundation and the vice president of Recovery Homes Collaborative. I want to thank the council for the opportunity to testify here today and for your significant commitment and hard work on behalf of individuals in need of treatment services for alcohol and other substances in their families. I've been asked to speak for about 5 minutes on the work that the organization does and how the city can help. Gavin Foundation is one of the oldest and largest comprehensive community-based addiction prevention and treatment programs in Greater Boston, and the Recovery Homes Collaborative serves over 40 programs across the state, of which the majority are in Boston. Programs Gavin offers within the city of Boston: prevention and education. The Speakers of Hope program, which is offered in schools and teaches refusal skills, goal setting, and building support networks. We do youth groups and sports teams. We have offered the Too Good for Drugs curriculum at the McCormick Middle School in Dorchester over the past 2 years. And this semester, we began providing the life skills curriculum to students at the Edward Middle School in collaboration with the Charlestown Substance Abuse Coalition. Intervention, the SAP program, or the Substance Abuse Program at the Counseling and Intervention Center, is part of Boston Public Schools, and it's for children who have been asked to leave the high school for drugs and alcohol, and we provide treatment while they're suspended from school and then they return to school. As an outgrowth of that, of the Substance Abuse Program, we are piloting what we're calling SAP Enhanced at Charlestown High School due to the large number of referrals. And from there, we do MET, CBT, and kids that complete the aftercare program are guaranteed a job through ABCD, Action for Boston Community Development, if they don't return to the CIC for the remainder of the year. Gavin also is collaborating with Boston Public Schools and Action for Boston Community Development to provide substance abuse counseling at Ostergard Recovery High School. Diversion program, total immersion program provides substance abuse treatment, case management, and drug and alcohol testing surveillance for several district courts in Boston. This program could and should be adapted for youth. We also provide the access to recovery for veterans and drug courts and returning citizens, with its focus on job training. We also work with the trial courts to institute the mission model to try to keep folks out of incarceration. Outside the city of Boston, we are working with a subcontractor to Phoenix of New England to offer ATS and CSS services, 64 beds in Quincy. In addition to, we work with Sheriff Bellotti on a Vivitrol project where Gavin sends folks into the jail to do engagement groups and then provide them with a Vivitrol upon release, and about 24% of the inmates are from Suffolk County or Boston. For treatment programs, Gavin operates outpatient programs, has 30 residential beds for transitional age youth and 106 beds for adults, and a waiting list of close to 50. We also provide recovery support service through Divine Recovery Center, which is, I hate to use the word drop-in because it's more than a drop-in, but it's a peer-to-peer recovery center where folks in early recovery or long-term recovery can support each other, not only in group settings, self-help groups, but also providing many social activities for each other in community service work, such as Boston Shine, which they participated in this last weekend. We are also a fiscal agent in oversight of the sober home inspections here in Boston and around the Commonwealth. So as you can see, Gavin offers a wide range of services, and our volunteers and staff and board have years of experience combating the disease of addiction, and some of who I consulted with prior to today's testimony. So how can you help? First, prevention. Institute a policy that ensures every student receives age-appropriate education on the effects of alcohol and other substances. 2, implement more pre-trial programs that would encourage early intervention without burdening someone with a record. I don't want to imply that every youngster who is drinking alcohol or smoking marijuana will become opiate addicted, but in my experience, most opiate addicted youngsters begin with alcohol and marijuana. Third, I would conduct a study to find out where the treatment gaps really are. We constantly hear we need more beds, but I would suggest that the real need is in long-term treatment beds. 4, create more educational vocational opportunities that would lift people out of addiction and poverty. Lack of economic opportunity leads people to continue to cycle through the system. 5, I would encourage you to support the 20 cents makes sense proposal to fund the education, prevention, and treatment and recovery support services so desperately needed. Again, I would like to thank the council for the opportunity to testify here today.
Thank you, John. Mary Ann.
Very good. And I am Mary Ann Frangoulis, and I am the Executive Director of MORE, Massachusetts Organization for Addiction Recovery. And thank you so much for the invitation, City Councilor Sabi George. And thank you, City Councilor Linehan, is also Presley. It's great to be here. And MORE's got a mission. We want to organize recovering individuals, families, and friends into a collective voice to educate the public about the value of living in recovery. And someday, the vision is to have a society where addiction is treated as a significant public health issue and recovery is recognized as valuable to all our communities. So you have assets all over the place. Everybody knows the horrendous stats that we had 1,400 deaths last year, with an 8% increase in the number of confirmed deaths. And this is across the state. Boston specifically, since the year 2000, there were 1,244. I got those stats from the Boston Public Health Commission. And what hit my heart is we were exploring doing a grant with the Boston Healthcare for the Homeless, that 80% of the people who were homeless that died last year died from overdoses. So it just, as you see it in one specific area of Boston, it hits your heart. That way to address it in a big way is really important. And you asked about alcohol, and when I got these stats, because I happened to be on an emergency room meeting looking at who's going to our emergency rooms with behavioral health, mental health, and addiction, and how do we best help them, and this is being conducted by the Executive Office of Health and Human Services, that in the past year for unspecified alcohol dependence, there were 37,308 people across the state in Massachusetts using our emergency rooms. So it's there in all kinds of drugs. And so the way is prevention, and then when you get them to recovery, maintenance. And then respecting those people that are struggling. That's really important, like any disease. We know that there are 23 million people living in recovery across the United States, and we are spreading the message of the power of recovery. We are, and we want to expand that move to help Boston. We're grateful members of the Office of Boston Recovery Services Committee, the Boston Faith-Based and Recovery Community Coalition, neighborhood coalitions, and affiliated with the many treatment centers that are here, as well with Boston Public Health Commission projects. A problem that we learned early on, because I used to be like advocate, and people would tell me as they came up, especially those in early recovery, is, hey lady, I don't know how to navigate this system, and housing, education, jobs, having criminal records, healthcare, insurance law. There's more and more support for people, and everyone here is trying to make that happen. But we specifically try to work on those issues and having conversation, and developed a curriculum to help that's peer-to-peer support. People need to know their rights to recovery. We also developed what some people called our little Bible, which is the more resources for recovery, a mini guide with more to come. It's about the services that are available and how to cope, how to get housing, what have you. it's not the be-all to end-all. It's something to hold on to use for support, along with many other resources. A solution that we're trying to do with many others, because you can't do it all alone, is to build a peer-to-peer support network. We have 8 recovery action meetings. We have 3 that are located in the Boston area. We do what we call addiction recovery education access meetings. Those are the peer-to-peer recovery curriculums. We have 3 in Boston, and we have recovery coaches, which you probably know are not clinicians, and they are not AA or NA sponsors, but people who mostly, not always, are in recovery that have been trained and learned the ethics of helping people to get to support to the next level. And through the Access to Recovery, some of our recovery coaches are helping people with housing, are helping people with like going to drug court. When you leave, say, a detox, and they say to you, we want you to go to 6 AA meetings a week and 3 NA meetings a week and make sure you eat healthy, and then everybody's like, I can't do that. So a recovery coach is one support way to get help and support. And there's no one way, as we all have talked about. We also participate in a SAMHSA grant with which is Substance Abuse Mental Health Services Administration Federal, to the Boston Public Health Commission with their Safe and Sound Recovery Center, and help with employing people for a short amount of time to get their feet wet for people that have never had employment. So they come into the office and do some support, and along with that, are involved in some of our projects and help them with their recovery center. We also are affiliated, as John mentioned with the 4 Boston Recovery Centers, and have celebrated 25 years of National Recovery Month celebrations, marching from City Hall to the State House. We do policy forum development, and City Councilor Asabi George was at our one in March. And it's a way of helping people to learn how government works, to exercise their rights. And when they get excited, like they were very excited to hear about Senator Keenan's bill that was going to move the 14 days to 28 days. And they're like, yes, let's make that happen. So that's all really good. How do we tell our stories to get to a point? There's a method of focusing on the positive so that people can understand what recovery is about. Lives change. And we, along with others, were very much involved in getting the Good Samaritan law passed and moving towards having people understand it. Why was that important? There were 15 opioid overdose prevention coalitions at the time that were state-supported, and they did an assessment and found one of the major reasons that so many people overdose and die is the fear of calling 911 because of the fear of arrest. We can see more positive things happening, such as with the police-assisted addiction recovery initiative, what our own police here in Boston are attempting to do. It's an important piece. But we're really grateful that our Attorney General is trying to promote public awareness around it, and it's tremendously exciting. And also our own people. I was glad that 3 years ago we had 3 people at the State House on a recovery day who are live because somebody called 911. They were able to get treatment, to go to recovery homes, and to get jobs. And then lo and behold, they're still around today, and one is part of that program, which is very, very exciting. We want to build the capacity to do recovery messaging. We participate in the State Without Stigma campaign, and a goal, like everyone, is to have immediate access to care along the way with long-term recovery support. We also believe in the power of prevention, and glad to see more school involvement that is going to be reinforced by the STEP Act that was passed, that all schools are supposed to do that. So what do we want from the Boston City Council? My goodness. More in alignment with our partners and in collaboration with the Office of Recovery Services. Would like to spread the word about recovery with messaging to all of our neighborhoods and to let them know that there should be no shame to this. We want to spread the word of our, mini guide with more to come, and to let people get more involved and make public policy fun, because it can be, and to be able to support the alcohol tax that's being proposed here. We like that 20 cents just makes sense, because it does make sense. So that's a real important thing. We can have great ideas, but we have to have ways to be able to financially support them. So it wants to build an alliance with Boston law enforcement to spread the word about the Good Samaritan law and support individuals and families who have overdosed, as well as to build the capacity to help the homeless who are dying in our streets. All of this needs strategy. You can't do it all at once, but to take one piece, one step at a time. And I thank you very much.
Thank you so much, Marian, and thank you all for being here today. Marian, how do we fund, or how are recovery coaches paid for and supported?
There are different ways. We happen to be funded right now, there's a year of that, I think, left, through the Access to Recovery program, which is federally supported. And it's for people who have mostly have had criminal justice problems. It also is for women who are pregnant and parenting. And there's homeless people, I think. And actually, the Gavin Foundation is one of the centers that you go to. And then you meet with a coordinator, an Access to Recovery coordinator, who will assess what are your needs. And then if you think you need a recovery coach, they will refer you to one. So that's one way. Then right now, our Bureau of Substance Abuse Services has now let it be for licensed outpatients to have recovery coaches in the outpatient. So those are two ways, and I'm sure there's others.
How are recovery coaches trained, certified? What's that process?
Yes.
They have a week-long, I'm sorry, man, they have a week-long training that they're doing. They're trying to figure out the certification process now, and they're doing what they call the CCAR model, which was developed down in Connecticut and has been going on for a long time. But
What's
they're
the
trying
model?
to CCAR, it's out of Connecticut, and they're trying to figure out how to do that so that they get reimbursed by more than the state, so that they will get Medicaid reimbursement.
Thank you. Council Linehan.
Well, again, thank you all for being here, and especially for what you do every day to make our city a better place. I appreciate your comments, and I know I've listened to many of you and worked with many of you going forward. But I'm going to just stay on my little task here of identifying dollar amounts. And I've been adding it up as each panel comes forward and have a sense. But when you talked of your 5-point plan, John, what's the dollar amount for that?
Well, Council, I think we were at 5 million coming into this, and if the 20 cents works, that would be, about 7 million left, so we could take 7 million and do as much as we could with it. I mean, we know that it's $6 million for the recovery home beds.
Right.
And the schools, it would depend upon what age bracket you actually pick that you want to go in and start to do the prevention. But I mean, we know through experience that when you started hammering away at smoking, the rate of tobacco use went down. So I think that we have to make the long-term investment and just start hammering away young.
I mean, I totally agree with you. The whole relationship between how the cigarette industry and the response, the campaigns to that, have truly made a difference in the overwhelming well-being of all Americans. It's just amazing, and we're not applying the same application. It's much of what you said and what you have said. So we need to spend a significant amount of money, and we need to go after people. We only have one culpable group at this time who could possibly be taxed. Prescription drugs in the United States cannot be. Marijuana is not a legal substance. So there's only one really at this time, and that's what the whole, 20 cents makes sense is about. And so if some of the programs that you added, if we talk about the outreach, or if we talk about Jen Leggett's need for whether it's better insurance payments or subsidies coming from somewhere to augment those insurance payments, then, the amount of money that we're talking about is over $20 million. And that's just for Boston. And I like to remind folks that we have 18% of the problem, and we have 25% of the services that are provided in this state alone. And we provide services throughout the whole region, which includes all of New England. And so I thank you for what you do. I've heard, I tell you, you do incredible work because it's taxing just to listen to, I'm serious, to listen to the breadth, the complexity, and the overall need. And think that this is just one issue that faces us every day on the city council. And, but, I'm focused on it, and I know many of my colleagues are. So I don't really have any questions. I appreciate what that you stood around for the third panel also, and for everybody in your industry for what they do. Thank you.
No, thank you so much, and thank you, all of you. I'm curious, Michelle, about the role of nurses in this care.
So part of it was a response from the state, originally set up by DPH BSAS, to create the ability to have the provider not be inundated with the number of appointments that it would take to manage a patient. And so kind of putting that nurse managed care model in place allows the provider to treat more patients because it's the nurse sort of driving the bus and seeing the patient weekly and really staying on where that patient needs to be on task. So that's where the model really comes from, and we've just seen it duplicated in so many, through grants, obviously through BSAS, but now more and more community health centers are just implementing that even just for regular disease models, and it's really becoming more effective because of the amount of time the nurse is able to spend with the patient. So it becomes like a health coach, so to speak. That answers your question.
No, that's fantastic. Thank you so much. Do any of you have anything else to add before we wrap up? I'd like to thank you all and thank all my fellow counselors who are here with us today and all of the presenters. It feels it's slightly overwhelming to me, and I've only heard from 12 of you today that are certainly among the hundreds, if not thousands, that are giving care to some of our most vulnerable in the city of Boston. But a few of the things I learned in my piles of notes here that I've taken, that prevention is absolutely something that we should, I know that you are focused on, and that we as a city should pay particular attention to, and that I've got a new appreciation for how wrong it is when health insurance is determining the quality, the level, the amount, or any access to care to those that are in recovery or seeking recovery face. And that we need to set, I think, some very clear expectations as a society and as a city on what those seeking treatment should get and deserve, and what their families and those that care about them should really come to expect when we talk about delivering care and delivering great care. And that there are some significant challenges with the loss of Long Island and the services that were provided out there and the services that we haven't yet been able to reproduce on the mainland. And that families and friends and those in recovery really need an incredible amount of support as they navigate the system to heal and to recover and to re-engage, and hopefully to continue a productive life here in the city of Boston. So I appreciate your time. I appreciate everyone that was here today, central staff for staffing this meeting tonight, and I look forward to certainly a continued an important conversation around a number of these things, and hopefully we get to some important achievements in the coming weeks, if not months. Thank you so much, and good night.